welcome you all to the second day of Anatomy Snippet series. And today we'll be discussing the topic of brainstem syndromes. A brief introduction about myself. I'm Dr. Ame Anil Munemane, intern and founder president of BVDMC Quizzing Society. So before diving into the topic of brainstem syndromes, which is a very important topic in neurology, covered as brainstem syndromes and also covered as a part of stroke. So brainstem is basically made up of medulla, pons, and midbrain, and it connects the spinal cord to the cerebrum. This is the basic anatomy that we should be aware of. Most of the cranial nerve nuclei they are present in the brainstem. So, like in your midbrain, you have third and fourth cranial nerves. Then in your pons, you have 5, 6, 7. Then in the medulla, you have 9, 10, 11, and 12. What is important is that medulla also houses some very important structure centers, which are the respiratory centers and the vomiting center. So what happens during what happens if there is a damage to the medulla is that these centers can get compressed, and that's why we say that the back of the brain is a very sensitive structure. We say that because of the presence of the respiratory and the vomiting centers that are actually present in the medulla. One more applied thing that is given in BD Chaurasia is that in hanging or whenever a person is given capital punishment, what happens is that when he is hanged, the dens of the axis vertebra breaks, and this strikes on these centers. So it strikes on the respiratory center, causing severe damage to the respiratory center and hence causing death by asphyxia. So this is one of the clinical applied that is given in BD Chaurasia in the introduction section. Let's move ahead. So these are some diagrams which have taken from Sobota's Atlas of Anatomy, a very good book for Atlas, apart from Netter's. So this is the medulla. The first image is of the anterior view, and the below one is of the posterior view. So in the anterior view, I can see the roots of trigeminal nerve, the facial nerve, the vestibulocochlear nerve, the glossopharyngeal nerve. So basically 5, 6, 7, and mainly 9, 10, 11, 12, which are there. In the posterior view, I can see various triangles, which are the vagal triangle and the hypoglossal triangle. Then this is the anterior surface of the brainstem, which is mainly showing the pons. Then the posterior surface of the brainstem. Posterior surface of the brainstem, you can see that it is divided equally into the midbrain, the pons, and the medulla oblongata, with stria medullaris, inferior cerebellar peduncle, middle cerebellar peduncle, and the superior cerebellar peduncle. So all three cerebellar peduncles are visible in the posterior surface of the brainstem. Then the midbrain, the anterior view, and the posterior view. So coming again, that the brainstem is made up of midbrain, medulla, and pons. Then we have discussed about the various nerves that are involved in the various structures of the brainstem. So repeating the nerves again, midbrain has third and fourth nerve, pons has fifth, sixth, seventh nerve, medulla has 9th, 10th, 11th, 12th cranial nerve. This is the only important applied anatomy that you need to know before diving into the concept of brainstem syndromes. So in brainstem syndromes, the first syndrome that we are going to be discussing is the lateral medullary, also called as the Wallenberg syndrome. Now this syndrome occurs due to the blockage of the posterior inferior cerebellar artery, that is pica, which supplies areas behind the inferior olivary nucleus. So how is the presentation of lateral medullary syndrome? Is that there is ipsilateral paralysis. What do you understand by the word ipsilateral? Ipsilateral means same side. So paralysis of the same side as that of the lesion of the soft palate, pharynx, larynx. This occurs due to the injury to nucleus ambiguus, which gives fibers to the 9th, 10th, and 11th cranial nerves. And there is loss of pain and temperature on same side of the face. Why same side of the face? Because of the involvement of the same side of the spinal nucleus and the spinal tract of the trigeminal or the fifth cranial nerve. Although, please pay attention here, there is loss of pain and temperature on the opposite side. Opposite side is also called as the contralateral side on the body. So on the face, it is on the same side, body it is on the opposite side. That is lateral medullary syndrome. There can be giddiness due to involvement of vestibular nucleus. So vestibular is basically the eighth nerve. The eighth cranial nerve is the vestibulocochlear. So there are two components there, which is the vestibular and the cochlear. Vestibular has got to do with your balance. So that's why giddiness. Then because that there can be ataxia of the limbs due to the damage to the inferior cerebellar peduncle. And then there is ipsilateral Horner's syndrome. So I hope you know what is Horner's syndrome. Horner syndrome has 5 things: ptosis, meiosis, anhidrosis, anaphthalamus, and loss of ciliospinal reflex. And there is a mnemonic here. Which is Pamela. Pamela. So mnemonic number 1 coming for you is for Horner syndrome. The presentation of Horner syndrome can be remembered as Pamela. Pamela, P for ptosis, A for anhidrosis, M for meiosis, E for anaphthalamus, and L for loss of ciliospinal reflex. A is just to give the addition. So A actually does not stand for anything there. So that is the mnemonic number 1. I'll be again revising the mnemonics at the end of the snippet 4, that is after discussing the MCQs, so that you can get a quick review. Then moving on to the second syndrome, that is the medial medullary or the Gerine syndrome. So if you remember, the lateral medullary syndrome was due to blockage of the posterior inferior cerebellar artery, which was supplying the areas behind the inferior olivary nucleus. Medial medullary occurs due to the blockage of the anterior spinal artery. So how is the presentation? Contralateral hemiplegia due to damage to the pyramid. Loss of sense of vibration and position due to damage to medial lemniscus. Paralysis of the muscles of tongue on the same side or the ipsilateral side due to the injury to the 12th cranial nerve. Okay. There's nothing much to discuss in medial medullary. And then combination of both lateral and medial medullary is called as Babinski-Nagioti syndrome. That is clinical signs of both lateral and medullary syndromes combined. So in lesions of medulla oblongata, we have discussed lateral medullary, medial medullary, and the Babinski-Nagioti syndrome. Medial medullary is one that can be seen on the screen in the orange colored box. Then 2 is lateral medullary, which can be seen in the blue box. And if 1 plus 2, then it is Babinski-Nagioti syndrome. Moving on to facial colliculus syndrome. So this facial colliculus syndrome is caused by lesion in the facial colliculus. What is facial colliculus? Facial colliculus, nothing to do with facial nerve. Okay, it is a elevation which is present on the floor of the 4th ventricle. It is made up of 6th and 7th cranial nerves. So in facial colliculus syndrome, the presentation goes like horizontal gaze palsy. Now, why there is horizontal gaze palsy? There is horizontal gaze palsy due to involvement of the 6th cranial nerve. Then there is perifacial facial nerve palsy because of involvement of the 7th cranial nerve. Paralysis of lateral rectus because lateral rectus is being supplied by the 6th cranial nerve. So here comes your mnemonic number 2, although not of brainstem syndromes, but you should know this mnemonic. In ophthalmology, it is very basic. SO4 LR6. All 3. What does that mean? The extraocular muscles, superior oblique is supplied by the 4th cranial nerve, which is a trochlear nerve. then lateral rectus is supplied by the sixth cranial nerve, and all other extraocular muscles except superior oblique and lateral rectus are supplied by the third or the oculomotor nerve. So because there is injury to the sixth cranial nerve, there is paralysis of the lateral rectus and conjugate gaze palsy, again due to the involvement of the sixth cranial nerve. So mainly if you see in facial colliculus syndrome, there is involvement of the sixth cranial nerve mainly and partly the seventh cranial nerve. Because of that, you are seeing three presentations because of sixth cranial nerve, which are horizontal gaze palsy, conjugate gaze palsy, and paralysis of lateral rectus, whereas only one presentation due to facial nerve paralysis, that is peripheral facial nerve palsy. Second is a Millard-Gubler syndrome. So Millard-Gubler occurs due to damage to fibers of the sixth and seventh cranial nerves. So there is ipsilateral facial paralysis because of the damage to the seventh cranial nerve. Ipsilateral loss of abduction of eye due to damage to sixth cranial nerve. We all know that the secondary or the primary, in fact, primary action of the lateral rectus is abduction. What do you mean by abduction? Abduction is away from the body and adduction is towards the body. So that's why abduction there is loss, ipsilateral loss because there is ipsilateral involvement, and contralateral hemiplegia due to lesion of the pyramidal fiber. So how do I remember Millard-Gubler syndrome is that you spell the word Millard and Gubler. So Millard is made up of 7 letters and Gubler is made of 6. So that's why it involves 6th and 7th cranial nerve. Again, the diagram taken from BD Chaurasia. So lesions of pons in the blue box, you can see the Miller-Gubler syndrome, that is number 2. Okay, now these are moving on to your ventral midbrain syndromes. So under midbrain syndromes, you can have ventral and dorsal midbrain syndromes. In ventral midbrain syndrome, the first is the Weber syndrome. Weber syndrome involves the third cranial nerve nucleus and the corticospinal fibers. So what happens? There is contralateral hemiplegia due to involvement of the corticospinal fibers, and the pupil will point downward and laterally due to paralysis of the third cranial nerve. So see, Weber syndrome is equal to ipsilateral third nerve palsy plus contralateral hemiplegia. You must have noticed contralateral hemiplegia coming again and again in the discussions. So that is one way to remember कि हाँ hemiplegia है तो contralateral होगा in case of any brainstem syndrome. Although it's not a rule, but like just an observation I have been seeing while reading the chapter that अरे hemiplegia तो contralateral ही है इसमें. And Claude syndrome is ipsilateral third nerve palsy plus contralateral ataxia. Why there is ataxia here in Claude syndrome? Because of the involvement of the red nucleus. And then Benedict syndrome. Just like you have, you had a syndrome, if you guys remember, Babinski-Nagioti, which was combination of lateral medullary and medial medullary syndrome. Similarly, a combination of Weber and Claude syndrome is called as a Benedict syndrome, where the tegmentum of the midbrain is damaged mainly. And if you remember in the midbrain, you had 2 cranial nerves, which are third and fourth. So yes, it will involve lesion of the medial lemniscus, red nucleus, and the third cranial nerve. So because third cranial nerve is involved or damaged, there is pupil which points down, see, downwards and laterally. Then there is tremors and twitching of the opposite side. Why? Because again damage to the red nucleus. There is hemibalismus due to lesion of the subthalamus. Hemibalismus is actually violent flinging movements of the limbs. That is what is hemibalismus. So it is one of the movement disorder. Violent flinging movements of the limbs, wherein it is happening due to lesion of the subthalamus. Tremors and twitching of the opposite side, because of the involvement of the red nucleus. Let's go to the dorsal midbrain syndrome, the Perinaud syndrome. Most common cause of a Perinaud syndrome is a pinealoma, which is a tumor of the pineal gland. Lesion of the superior colliculi. There is upgaze palsy, vertical nystagmus. Why? Because of involvement of the superior cerebellar peduncle, light near dissociation, and Argyll-Robertson pupil. Very important concept in ophthalmology. In ophthalmology, we learn about various types of pupils: the Marcus Gunn pupil, the Argyll-Robertson pupil, the festoon pupil, many other pupils that we learn. One of them is Argel-Robertson pupil, where you should remember that the accommodation reflex is retained, but the light reflex is lost. So here in Perinaud syndrome, I have got two mnemonics for you. The first mnemonic of Perinaud syndrome is Perinaud syndrome starts with the letter P. Pinealoma starts with the letter P. Pretectal, uh, P, it starts with P, right? And pupil, Argel-Robertson pupil, na? It's a special type of pupil. So that P. So these three P's are there in Perinaud, that is P. Mnemonic number 5 is with respect to Argel-Robertson pupil. Argel-Robertson pupil starts with the letter A. So accommodation reflex would be there in that type of pupil. So these are the 5 mnemonics. And then you have the Knoth-Nagle syndrome, which is bilateral third cranial nerve paralysis, ipsilateral contralateral gait ataxia, and vertical gaze palsy. So in both Perinaud as well as Knoth-Nagle syndrome, you have vertical gaze palsy. So you can see this. Okay. So this marks the end of our brainstem syndromes. We have covered midbrain syndromes, pontine syndromes, dorsal and ventral midbrain syndrome. Dorsal and ventral midbrain syndromes, medullary syndromes, pontine syndromes, and we have discussed 5 mnemonics. I hope this session was apt, and I've tried to cover as many things I can within a short span of time. If you like this video, kindly share, subscribe, and if you have any comments or suggestions, please email us on our official email ID of Quizzing Society, bvdomcquizingsociety@gmail.com. Hope to see you again in the snippet 4. That will be the MCQ discussion of brainstem syndromes. Thank you.